I think what we want to do is identify statutory modifications that might be necessary. There are a number of statutes identified in the versions. For example, MnStat 253B.1 subdivision 1 paragraph B. That one, there are a number of them. What kind of legal law changes do we need to effectuate meaningful change? Yeah, so it's going to have to be kind of a general dialogue, but if we want the law to be different. So, for example, and there's a lot of statutes in here that are exciting, like the provision about in the jails, like the waiver stuff, and there's a number of things that need to be changed. So I don't know if anybody has any ones that they're thinking of right off the top, but it would be nice to list the statutes that we think need changing and propose the language that we think needs to be changed. That would be a good way of being effective. I can tell you that the legislature is one where if you have a clear sense of what you want to do and you have enough people to advocate, you can move it, especially if it doesn't cost any money.
So what is our legislature? Talking about changing some of those policies, both talking about things that will funding and so how much, what are we doing?
Let me just say this about the funding part. And this is a philosophical point. I'm not right. I'm not wrong. It's just my opinion. Ask for what you need. Put somebody else in charge of telling you no. There's plenty of people who would love to. But what? Don't tell yourself no. And and because here's the thing: sometimes you get what you want. Sometimes you get some of what you want, but then you've introduced the topic so that you can come back. But if you self-censor too much, you end up getting exactly what you tried to get, which is not much. So that's my thought. Make them make a decision. That's what they're elected to do, is to decide things. So make them decide on this thing.
A policy that we have that in principle. I agree on that.
I would recommend it. I don't know how people feel about it.
Yeah, I think we need to have something in there with funding.
Yeah,
Absolutely, with the monies that is going to be spent and where it's going to come from or whatever. Maybe that's later, but there definitely has to be a number in there that we're shooting for.
yeah. I would also say don't put in more than you need.
You said
Because-
shoot for the Starsky.
Here's the thing about it. Right. You want the legislators to get on your side and help you out. If they can show you don't need as much as you're asking for, then that might undermine your credibility. So you want them to believe you. So you want to be able to show your math, and here's why this costs what it costs, but it does cost what it costs. So pony up. So that's my take on it. So there's a certain amount of money that I think we should ask for, even if this is going to be a tighter budget year. By the way, they're not in deficit. They're just not in big time surplus like we were over last year. And yeah.
No, he's finished.
I was going to say, but then there's some policy things that need change that may not require any financial output. And those things, this is the kind of, this year they specialize more in budgeting, not budgeting, bonding and policy, and some supplemental budget. So there you go.
Going to suggest, and it's true in both of the versions, that number one is the same modification, which is the statutory modification. It's also pressing because the current modification to the priority admission statute sunsets in 2025. The version that the county partners put together is tied to version number 2, which is not free at all. And 2B, which I would add is increased capacity in DCT and community. So personally, I would really like to start with number 1. If we could get agreement on that I think much of the rest will.
So layout number 1, so everybody understands.
Number 1 modifies the priority admission statute so that prioritization is based on intensity of treatment needed and those other factors that we went over, rather than let's prioritize from jails first. But there is monitoring processes, oversight, whatever we end up calling it, to monitor how that's going and to then make recommendations.
So let's discuss that. Anybody have thoughts on that?
I do.
Yeah.
My concern, and I think it would be for 87 sheriffs, of being dumped on, of that becomes our responsibility. And it's not just the county, but me personally, I'm for the care, custody, and named in the lawsuit to be deliberately indifferent when I don't have all of the process that I need to do that. So if having guidelines in there, like Keith had said earlier, that's helpful to have a number that can say, hey, what's our remedy for this, instead of just taking it and saying, well, there's nothing to do. We can't do anything. We're just sitting there. That they're just sitting there.
Would it help if we paired that not only with number 2, but what was it, number 5, that talked about increasing access to services in jails? 4, number 4. So that jails aren't left on their own trying to manage.
Yeah, so you're saying that it wouldn't be like the jail's responsibility to do that. It would be in a partnership, or what does that look like? What do you?
I don't know.
Yeah.
I don't know. Be something. I think we all can agree on that.
I mean, I'm assuming it would be more of a grant approach, right? Because you don't know who in which jail is going to need the medication at that point. And then, whether it would be like, I do think it should be funneled through the community mental health center. So when they leave, they still have a prescriber,
Right.
which is helpful. But I would think we would have to do it like that. It wouldn't just be giving all the jails some money. It would be, we have this pot of money. If you have somebody that we can get the drugs for. And I think as we're looking at these recommendations, knowing like, I don't think any of us would say just this one, but I think if you just look at it and say, yes, this language is we've agreed to, but we know we have to do a whole bunch of other things and then go through them to add to the list would also be helpful. But I think the combination of the 2 that we already talked about makes that recommendation kind of work, I think. But then we need to have these other things too.
Dr. Hart?
I'm just wondering if part of the solution could be, and I'll just say 48 hours because that's what we've been talking about. But if you have somebody who is committed, or you recognize somebody who is severely mentally ill, within 48 hours you make a referral for telehealth. So then you started the process of trying to get them some type of care, because if they're in your jail, I don't really feel like you can give responsibility to somebody else, even if it's the state commissioner. If they're in your facility, I think you will still be responsible for trying to get them care. But if you make the referral, and then I don't know, this oversight committee that was going to be helpful with reviewing admissions, could they also be tasked to make sure, like Sue was saying, that the person, like there would be a point of contact for them if they're not getting their medication, and somebody helping them problem solve, but like something, there's some accountability, like every certain period of time, if they're still there, there's some way for you to get services. So you don't feel like you're on your own, and the patient feels like there's something happening, even if they're sitting there.
I think we were talking about this this funding to be more.
I'm sorry, Sue, could you talk up a little bit?
Yep, but I think on this recommendation, we're talking more about, injectables, right? Than or other Jarvis orders, not just any medication.
I was thinking, no,
That's what we, yeah, that's what we hear about mostly, and that's what is most impactful. typically.
Sometimes it feels like a hot potato with Jarvis. Who starts it? Is the county? Does the county attorney? Does the sheriff? Where does it start and initiate from? Whether if it's in a hospital setting, nobody seems to want to take the ball, and sometimes it gets dropped there. It'd be nice to have clear language of, if this happens, then this.
some kind of decision.
Yeah, absolutely. Of like,
And that's the policy change that we're talking about, so that the Jarvis orders could come from jail and not just.
And it starts at the time of the forensic examination, for example, where
before the first 48 hours.
as soon as the person's deemed incompetent.
Well, but that might be 3.5 months.
Okay, I mean, if there's a faster point in time, absolutely.
Well, because we want to get to people quicker to get them
Yeah.
help
Yeah,
immediately, instead
yeah.
of
Upon referral, maybe.
exhibiting.
How do you concern about the cost? We're doing some of that in Hennepin County, right? So all of a sudden somebody's saying, well, what little resources we're committing to Hennepin is not enough. Once you start to do petitions and follow that through, you should bring more people in, and then the question becomes, who pays for that? Or does the jail fund those services? Where is it going?
For the Jarvis hearing or for administering?
For both. For both. Because for Jarvis hearing, you need to have somebody who does the exam, who's a part of the process. Somebody
Right,
who reads it. Somebody's gonna do a report. So if I'm the physician in the jail, I need to sit down and figure out, have they been treated with antipsychotics? Do I have any records about what they've been treated with?
Mhm.
Is there any adverse report? I need to fill out a form and submit that form to them. So who does that? And yes, I can come and do that. Who pays for that?
Does Medicaid cover that potentially?
No, it's shut off once it's in the
No,
jail.
no, if the 1115 waiver goes through.
No, because it's the last 90 days.
What if it didn't?
If
Maybe
it isn't, then yes.
Potentially could,
It should.
potentially, not for all, because not everyone is
It's on
covered.
Medicaid.
So, it could.
So if Medicaid, just shorthand a little bit, so if Medicaid is not turned off when someone is incarcerated, some of this could be billable, which would help offset the funds. Right? Do I have that right?
That's right.
Okay.
So what's the process in hospitals for what?
After the patient is there, usually we try to do it at the same time we petition for commitment. So if there's not some separate hearing, obviously, I'm gonna get it is by reviewing the record and writing a statement about why it's a pretty standard form.
So you've got the capacity to do that there, if you have the mental health professionals.
Right, and I have the electronic record, so I can just push a button and send it, to somebody who processes it.
My understanding, I know Angie can correct me because I don't know what the policy across the county, other counties, but typically in Washington County, when there's a need identified, it goes to community services, they petition, and our office is the one that files the paperwork, but it always comes from the community services people who are doing it. Now, I think it has something to do with the county of financial responsibility, but for the people that Washington County is responsible for, which is the vast majority of the people in jail, our community services, they're doing that.
So I almost wonder if this is like a side little work group to think through how we could get Jarvis's fastest paralysis setting. Is that?
Yeah, there's some nuances with that I think could be, would take the rest of today to talk through.
Right.
I think it's doable. I think there are pieces that really need to be examined closely. I do think, Dr. Stevens, if I understand the California model right, the key with that, again, is that it's state funded and standardized so that there's not, in Minnesota, 87 different ways and 87 different levels of funding. And, like the standardization piece is key to making this work. And so as we may talk about this into the future, I think that's critical part of it. Well, who would pay for those services for somebody who's not Medicaid eligible? Would the jail end up paying?
Way is now.
It is now, yeah. County does.
Right now, the jail would. So it seems like we have to account for those folks too, because it would be difficult for you, I'm imagining, for you to pay for those services for those people who are not covered by Medicaid.
But that pot of money could easily, you're just going to, that pot of money could be used that same way. It doesn't matter whether, because Medicaid eligible doesn't matter until we could bill Medicaid for it. So that pot of money, just anyone who needs those medications, you would go for it. So it wouldn't matter.
And like you said, you're gonna have 87 counties, 87 different ways, and people are gonna prioritize how they're gonna spend money, and do they really need to do that? And it would be nice to have something standardized, say, from the state, this is what's gonna happen. Versus someone locally going, we're not gonna spend money, people are fine. Not that I've ever heard that.
And
This is the reason
I'd just
behind
like
your
to
number
comment.
4, that you put that as sheriff's association, but that our point of 4 about. Yeah, I know it's a big lift, but I think that's the idea.
Just wanted to comment how important I think this discussion is, because if the Jarvis order is when me getting properly medicated is when my recovery began. I think it's very important.
That's a big deal. And I appreciate you sharing that, because it's real life perspective. So even, I mean, you got it. So here's the thing I'm kind of sorting out. Maybe I'm confusing some things. So if you have a Jarvis order issue and you are now going to be involuntarily medicated, Medicaid, and that's still on your nickel or the county's nickel or somebody else's nickel.
If they're in jail.
in a jail.
They up there.
Yeah. You
Or
would think
if
that
they're
when
in
the
the
state's doing that,
Or the state.
you would think that it would be some governmental entity that would cover that. If it's involuntary.
Remember, state dollars are paying for the involuntary medication at DCT as well.
Right,
Okay.
all our pharmacy budget is.
Right. Because of the way Medicaid works.
Well, let's continue. So do we have some general understanding around that?
1, 2, and 4.
Yeah.
Or no 1 without 4, or versions.
I would say,
Wordsmithing.
yeah, not number 1 has to be linked to number 2 and 4. It just does. 'Cause otherwise we just lose so much.
Do you want to speak about the capacity? We haven't touched much on that yet today. The number 2.
Number 2. So the capacity piece, yep, and so every place that says bed, insert and staffing. So, because just simply having beds is not sufficient for treatment, right? We know that we have to have staffing to do that. What we have listed here is that we know, and so this is kind of paired with what we have in short term, number 1, kind of using a model. So I was thinking back to what you said at the very first, like, do we have a goal that we're shooting for? Do we know what that capacity looks like? And so the American Psychiatric Association has a model. It takes a lot of time to kind of work through to say what type of bed capacity is needed in a certain city, county, state, something like that, right? So it's based on a lot of science. And so thinking about that as a longer term thing, we, and I'm taking some liberties to say, we would believe that whatever would reasonably be funded for bed capacity would not meet or exceed the current demand. Because right now we know there's hundreds, if not bigger than that, number of individuals waiting for hospital beds, right, in the state. We're not talking about adding that many beds. I don't think that it would be reasonable to put that type of a proposal forward, but that we would look at adding beds and staffing in
the areas of forensic mental health programs because forensic is full and overflown into AMRTC. So in a perfect world, forensics would be contained within forensics and not overflown into AMRTC. Then we have ANOCA, Metro Regional Treatment Center, so that there could be additional capacity there. And then additional capacity in the CDHH system. And then additional capacity with community support services team. And so that's really working on that transition piece. So that's not, D is not beds. D is some really specialized staffing to help the community continue to serve individuals. I would say that the part that's not written on here is also a community capacity in terms of beds and staffing. So that's also something that we talked about. There needs to be some further expansion in those ways.
I would say if you do 1 and 2, that instead of DCT, it also has to say DOC. Because I think you can have some type of forensic treatment unit, some type of intensive mental health treatment built into DOC. Because you're not going to be able to take care of it without DCT services. There's a 1, 2, 4 plus that we can do.
To allow for a pathway, Department of Corrections, like the prison system.
To have some built-in treatment within. So whether it's some unit within or the residential treatment centers that are like in Colorado, but I think you have to also expand treatment capacity within DOC.
So this one,
48 hour.
Does that move people like out of jails?
and get put in prison. So it was actually a big discussion this last session because DOC for Oak Park Heights wanted to, because they weren't using all of the beds. There's already language where they could move some people from jail into that unit. But there's, big discussion. It's like, well, these aren't people who have been convicted of a crime. Why would we put them in, in a prison bed? So they could do that now. But there was really a lot of discussion about that.
You're working on a pilot from what I understand.
Great.
Yeah, and I know that one of the proposals that they made, at the Sheriff's Association has made is that.
Can you talk a little louder?
One of the proposals that the Sheriff's Association made is to do something similar to like what they're doing within DOC for jails, so that there would be jails with capacity, regional centers where you could transfer people that are higher need patients that are detainees.
I work for the federal system. We have mainline institutions. We also have the federal medical centers of people who need intensive medical and mental health treatment. We routinely have people there for long term who are legally pre-trial because they're committed for mental health treatment, and they're not housed in the same room as somebody who is sentenced. But we have people who are pre-trial in the correctional facilities getting mental health treatment because they're committed. So they're mentally ill and dangerous, or they're committed to the attorney general and get treatment in the
It's a medical center though. It's like, is it part of the prison? But it's a medical center. It looks like a medical center. Functions like.
So this, and I'm just going to have to add, because I had concern even about the pilot. So I think that is something that would take a whole lot more discussion to come to an agreement with, because it was discussed a lot this last legislative session.
Thank you.
So I just saying.
So what were some of the concerns from the advocates?
Well, that you're sending someone who hasn't been convicted to a prison setting.
Yeah.
And, and then typically even farther away from home, because Oak Park Heights is not, necessarily central, wherever you are in the state. And I thought it was Dakota County that was looking for money from the bonding bill to create a jail that was more equipped to deal with people with mental illnesses who were coming in initially before they've even, been deemed incompetent and things like that. So I know that issue was before the legislature. But I mean, if we had our druthers, we would just try to build more in the mental health system than in the correction system. to really kind of keep that piece going.
I agree, we do have, should definitely have more in the system, but I don't think you can ignore having some capacity with the DOC itself, because there's gonna be people who need it.
Well, and they do have the pilot project. But I think you'd have a hard time getting the mental health legislative network to agree to put more money to add specific beds in the Department of Correction for people from the jails who live in mental illness.
I guess I'm thinking more about the people who are already in the jails who haven't.
Those
Not
are the people
taking-
we're talking about
yeah.
here, but again, they haven't been convicted. So
Is it possible to have regional facility, a jail facility that would treat mental illness in different counties, so they're in the jail setting or not? And
that's what Dakota was trying to.
just to repurpose what's already there and redistribute people that need care to one facility.
Should this group recommend a bonding proposal? You don't think so?
I don't think
So
we
the-
should take it off the table.
I mean, and the CBHHs, they can't actually add beds because once they add beds, then they can't get Medicaid. So that's just something that people need to know. And they are at full capacity now, is my understanding, pretty much.
We need to add hospitals.
Yeah, so then we'd have to add beds.
Yep, that's what that was written. Said, yes, not to exceed the 16 beds because that financially leaves us worse off. It would be adding an additional CBHH.
But I'm hearing some support for exploration of regional, I don't know what the right wording is, but regional treatment centers operated by jails, basically, that have treatment
Operating
centers.
in jails. I think the proposal is.
No, I think it's kind of twofold. That would be, then regional response teams will be in the jails initially until capacity could be built regionally. And then those response teams that are already having working relationships with the counties in the jail would fold back into that facility once the capacity is built to be able to train and maintain a relationship with counties and get the help they need. DCT, yeah,
Personnel is what you're thinking.
correct. Yep.
But the facilities would be DCT operated or
I didn't think
Jails.
that far. No, it would be state.
Jails would
So
provide
regional
the
treatment
facility and the
centers?
staffing, the operations would come from the state.
Like a
I don't
partnership.
think that's what Dakota was thinking, but
But
at
it's-
least from.
Initially or long term? Initially, yes, it would be at the jails. Where the response teams, or regional response teams would be there to administer, do the Jarvis, get the physician statement.
Sheriff, are we talking about add-on physical
No.
construction
No.
onto the jail or no?
No, because
Okay.
in my mind, I'm thinking, I already have them people in jail
Okay,
and they're taking that space regardless.
Okay.
And this is us doing something instead of watching them languish
got it.
until capacity is built.
Let me ask you that. Yeah, so that's what I was getting at. Is there more physical space needed for jails or are we good how we are?
I think you're talking about a whole separate facility.
Right.
Or
Yeah.
a regional facility that these individuals could be.
Right,
referred
you're not
to
talking about-
county Jail.
That's the long term.
Yeah,
Long term, yeah, it would be like, just like the BCA has your north, central and south laboratories that deal with all the northern counties, the central Minnesota counties, and now they're building one in Mankato, kind of that same concept of, okay, how many, obviously you're gonna have a bigger facility down here than you would in Bemidji.
so.
That makes me nervous. I'm just gonna be really honest. And, again, then we bring people even farther away from home. If they do have a provider in the community mental health center, they're even farther away then from them. It feels like, if we wanted to try one as a pilot to see how that works, but I also feel like, again, we're building up jails instead of building up the places where we need people to go. And
I don't think so because of like in our county, for instance, they're going down to St. Peter. And that is a struggle for people to get there from our location. And it would be easier to get them to the Division, which is 14 miles away from the northern end of our county, or 100.
For the CBHH, that is not that, you know. So, I mean, I'd rather build a CBHH than a jail.
Well, I don't think it's
That's
building a
not the-
jail.
It's not building a jail,
No,
it's building a
it's a-
regional treatment center
yes.
operated by the state, right?
Correct.
For the people who are already in custody.
Not necessarily.
Well, they haven't tried yet.
No, not necessarily. I would say for building capacity for all of that, all the above.
I guess for me, it's not a either, like you have to do both. Because again, largest mental health providers are correctional facilities. So those people need treatment there in those facilities. And this would be a way, if they have very intense needs, there will be a place for them to get the intense treatment they needed.
But how many times are people in jail because there's nowhere else to go?
And we can only
Too many
compensate
times. So it's not
facility
about
actually provides.
incarceration, but about keeping them safe and other people. So I know they're at our level of the jail, we're often the only answer because it's immediate. It gets people safe, but it doesn't do anything. And this would get somebody to start the process, do something, and get them the help they need, I guess, and start that process.
Yeah, I was just gonna comment that, anything that I was charged with the crime, I got expunged. But just requesting police reports related to my specific case, from the areas that I was in, whenever I was struggling with my mental health, I got back 70 or 75 pages worth of contact with police. It wasn't anything I was charged with a crime with, because again, that was expunged.
Right.
So there were a lot more pages that just aren't available anymore. But this was just documenting contact. And there were many times I was locked up. Just briefly, booked, released.
Right.
Other times held overnight.
Right.
So
Because that gets that, on a weekend when nothing's going on, or I mean, nothing's open, that's the answer where they go. At least in northern Minnesota, there's no place to bring people. And that goes for detox and that goes for mental health. It's a catch-all. We don't have a detox. And I know a lot of that stuff wouldn't be charged out criminally, which it shouldn't be. And if we can get them to them places, it would help unclog that. And I don't know if this is the appropriate time to bring that up, but when we have people that are assigned to the Department of Human Services and they're in a group home setting and they do something that requires a response from us, it would be nice that they wouldn't go to jail if they're under that already, because something happens. One of the calls that I was personally involved in, group home response called boiling water on another person that was there and hurt him pretty bad. So he couldn't be in a hospital. There's nothing medically wrong with him, but couldn't be back in the facility. So we bring him to jail and they quickly determined he's been Rule 20 before. So that they have to go, that was in a different county. So now Cass County has to start that whole process over to make him Rule 20 in Cass County. And it sits there for 3 months or 3.5 months till that process happens. And if it's already been done, why are we redoing it and putting him through it and letting him in the jail? That's the part that's like, why are we doing that? We already know what we know. It's already gone through that process. And that's a clogging up issue because if we get 3-4 of them, that doesn't make any sense.
They're
To me.
doing that so they can get access to Anoka.
Correct.
Wouldn't it be better if we could come together and figure out a better living situation?
Totally agree. And especially when it's already been done.
One issue I don't want us to get away before we go is the next proposal having to do with authorization of the rape study, which I believe will attract that workforce. I mean, what have you all, I'm not sure who said it, maybe it was Ed, who said that anytime you say bed, say and staff. Well, we need more people doing this work And this the closest to, this is the closest proposal we're making to getting more staff that I can see. So,
It just says implement though, because it's already authorized.
all right, it's already authorized. Okay,
Yes.
right. So in terms of with the new funding, there's going to have to be some sort of an appropriation bill for it. And what are we thinking in terms of that?
Well, they have to do the fiscal note. I mean, we
Right.
can't come up with that number, but
No, we can't.
the rate study, I think, well, the department would be able to create a fiscal note based on the rate study.
Do we need legislation in here? I mean, okay,
Only to implement it.
all right.
So once the rate study is supposed to come out, what, in January, I think?
So number
Yes, we do.
7 would actually be crossed off, and it's under long-term implementation of rate study findings. And I would say that I just took liberties with, are they immediate, short-term, or long-term? Now, if those findings come back and we want to move that around, that I think that's really up to the wishes of this group as far as, is this short-term, long-term, immediate, that it's on here. And I think that it could really be, we could add the additional pieces behind it as to why. Why is this so critical? It really goes to every recommendation in here. It bolsters every single recommendation. The shortest one. Possibly the one of the biggest.
And let me ask you, if we, if it comes back recommending higher rates, is that enough to staff the needs that are being contemplated here? Is one lead to the other without any much more than that?
It'll help in the community, but there's still shortages, which is why the other things around, we had lots of people licensed, or lots of people who graduated and didn't get licensed. So the supervision money and things like that will help get people across that finish line.
Mm-hmm.
So it isn't like this will help, but there's still not enough people.
Right.
So
when you think about outpatient mental health services, a lot of mental health centers operate at a deficit, or they need the grant funding to support it. Unlike some other healthcare services where the rate actually pays for the service, this doesn't even, and honestly, it doesn't even come close to paying for the provider's salary, let alone the overhead of the facility and the electronic health record and all the rules and regulations and all the policies that go for providing holistic services. The rates don't come close to reality. They just don't. So I think if it could pay for it, yes. Would it be more attractive? Potentially. When we look at, this is a little bit different, but in under short-term number 2, increased Rule 20 examiner availability. Now, I understand those rates are different that we're talking about. They wouldn't be funded under the rate study, but it's the same problem there, is that the rates are not sufficient to keep people interested in this work, or to take on the risk and liability associated with providing services, because there's a lot of inherent risk in providing these types of healthcare services. So I think it will definitely help. I think when we talk to providers about saying, hey, we have this need for this type of service in our community, and they say, yep, that's great, but how much is the county going to contribute to cover our costs? And we say, well, we don't have that. The conversation ends there. We don't get increased capacity from a community service standpoint because of the rates. Hospitals feel the same exact thing. Same exact.
Address the number 1, the actual tank for the language of the that under the version 1, suggested that we hospitals members to offer that for just put all the deals first and never get to the hospitals in the community. And convince the lista to make people comfortable that we are implementing that well. We offered that people might monitor that process for a year from this group. People from the on this draft that came from the county group, it's turned into an oversight committee with appeals processes and all sorts of things, overseeing pre-admission screening team. And we believe that the pre-admission screening team needs to have the freedom to figure out who comes into the facility based on the criteria we've all talked about. Additional oversight. So we'd like to talk about how that is strictly written in the one here and the other. That Stevens pre-admissions group have the same authority they would do their jobs. If you're willing to share the result of that, on a quarterly basis, so you can see what happened after this task force. And here's how it's going now. And now it's not this pendulum. We're trying to bring it back to the center. That pendulum back to the center. And show that we're doing that. When you talk about oversight, it's like they're going to report to the group or something, and then the group having appeals authority. How does that work?
I think we mixed the appeals thing already now in our meeting this week.
Well, we talked about it in our smaller drafting committee. I don't know as though I think the concept of accountability is maybe the concept. And so is it, whether it's the specifics written in here or there's an agreement to something else, I think, earlier there was a comment about what does 48 hours equal? It equals accountability. And I think what we're saying is, okay, with 1A, there's no hours designated, or there's no accountability factor. 1B would be an attempt at an accountability factor. And that's what you have in version 1 as well, as some type of review group. And I think that's the intention, is accountability. I think that the main difference is that in version 2, it wouldn't be limited to just a year, because honestly, that goes by so quickly, and this problem is so long-standing that we may need to monitor this much longer than a year. And then also for I would say when this was written, it was not with the intention of having patient by patient information and influence on who gets, not to take the role of central pre-admission or anything like that. It's still written, I think, in here 4 times a year. That's not responsive to individual situations, but to provide actual guidance over some of what would happen in number 1 with the prioritization tool.
But if I may clarify, central pre-admissions doesn't act autonomously. They serve as a facilitator or a 911 call center, if you will, plugging in whatever the need is with where that person should go. Sometimes it's EMS, sometimes it's fire, etc. They are working at the behest of the physicians that are responsible for care and quality of care within direct care and treatment. That is something that must be maintained for many reasons, including regulatory reasons. That's not something that can be done by committee, and whatever we decide we can't be interfering with the daily operations and individual decisions. So, respectfully, we can't talk about every single individual, because CPA handles 5,000 calls a month, and many more emails than that. So it is a 25-person team that is working literally around the clock to make things happen. So anything we do that involves oversight, et cetera, decision-making is going to grind it to a halt. And I would note, over the last several years, we've made significant strides in admitting more and more people, treating them more efficiently, getting folks out more quickly, and being recognized for our quality of care. So I feel that needs to be said in this group, that we are doing good work. And we are happy to share, we are happy to get advice and be accountable. But we can't have processes introduced, particularly as we're trying to separate and create our own organization, that's going to grind that work to a halt.
On one hand, the commissioner was thinking is a group that would look at data and then reflect on how the process is going. I don't know what sort of power this would have other than to observe and comment, and so I think that that part I don't understand, but and then there's a discussion, that you're talking about is, well, what rights do individuals have? So if someone's sitting in jail and they've been there for 6 months and they want to have a third party look at their situation besides a court, for example, what recourse does someone have for defense counsel to say, I don't know what decision you made here in terms of your priority, but I'm watching the person completely collapse. So how do I get them up the priority list, get your attention, and make sure you haven't missed something?
And that's a fair point. My question back is, how do we then explain why that person is not at the top without revealing protected health information of the people that were admitted or that are higher up on the list? I don't know how to do that.
Except, it depends, and of course, this is what Dr. Colon and I were talking about before we started. The diagnostic problem with the discretionary part of the time of this is my art and science. So I know you can't articulate a formulaic standard that someone can say either applies or doesn't apply. But on the other hand, I think all these mechanisms that we're talking about are some way to have, a government agency who's doing a great job, but for some accountability, not that they're not doing a good job, but it's for no other reason than to give the agency leverage to say we don't have the capacity to meet our obligations on this, and I think that was the original intent by some of this accountability stuff, is so that others could say that, okay, here's how you measure the need, and the funding for that is inadequate. So we need to expand that agency's ability to meet its obligations. So
I'll back you up.
I would offer that in the intention of version 1 is transparency, not accountability. Show this group who think this all through. It's going now for a period of time. The year was a lot because of the fact that this change to the rule right now. For 2025. What's happened if we change it again in another way? And then when 25 comes around, we figure out the whole rule.
Yeah. Does it go away then
Reverts back to the original
in 13, or it goes away?
in 25.
This is a 2-year.
No, but I mean,
Oh, right. 48 hours.
Would be-
Jails only.
So you want to get in here?
Well, I actually agree with you, Commissioner. It isn't really about accountability, it's about progress. So, do you have a whole bunch of open beds? Well, that's accountability. If your beds are full and there's just a long waiting list, that's not accountability, it's where are we in that process?
Yeah.
And so I think changing the wording there actually might be helpful, because we do want to know, right? How many people are on the waiting list? Where are they from? How long has someone been on there? And is that getting better because we're doing things in the community and because we've been able to staff up so you can take different people. I think those are the things that we have to look at.
And the author was to sort of take the mystery out, because people say they don't know what that process is and who gets to the top of the list. Well, if we're going to add hospital and community, then let's show how it's worked and show how the process. We're thinking of the dashboard, who came into AMRTC, who got through DCT, who's coming out the other end, where are they coming in aggregate data. Saying, well, now that we all talked about it for a while on this dashboard, it's playing out. But the terms oversight, you would have some kind of appeal authority in the sense to get the very rapid responses we need to do every day to manage the hospitals.
in the spirit of that, the transparency, it would be nice from like a standpoint from us of like being able to see that information real time, saying we can't have any expectation because here's where they're at, the numbers level of like you said, a dashboard of like, hey, they're at near capacity. We need to be thinking alternatively. Even if we build 1,000 beds, at some point it's going to be full. What do we do then? then we need to kick in a secondary process, or just knowing that, like you said, what the process, or I'm sorry, the criteria is for that, and training our people that, do they meet these? Can we help find some of that stuff that they need, and instead of doing a whole new assessment, here's how we can help make this process faster, and maybe not even get to that. Knowing the information and what you have for numbers, where they're at, and what we can expect. So it isn't all of a sudden, oh, I called on a Friday or a Monday, they change the numbers because I called. And no, here it is, it's been there, it's not changing. I think that would be very helpful in the transparency and the trust and buy-in. Like you said, the silo effect would open up and say, here's what we know, here's where it is.
A real-time dashboard that would be accessible.
Yeah, to people, to partners that, not to everybody, obviously, but it doesn't need names, as numbers that are like a jail administrator, our health and human service people that would be stakeholders in this process.
And the transparency is a good component of it. I think that all these things become possible if we can recommend something that floats all boats here. I think that's the challenge. Because to be frank, I think it would be very difficult for the four of us to go back to our county organizations and tell them we've agreed to trust DHS to move us along, but we're going to, things are going to get a little bit worse for a while, and then they're going to get better. I mean, in a better world, there would be that kind of ability to do that, but I've been hearing from some of those folks, and it's an uphill battle to even do kind of what we're doing.
I understand that. I also have some buying number one to number two, given the state of the state forecast. I don't know that we're going to get the capacity you're looking for when you want to tie these two together. And I just have a real problem leaving some of these patients in hospitals for another year because we didn't get the capacity funding we needed. It won't change the 48 hours.
I know that you've talked about some of the capacity you're working on this year. Some plans that, frequently. Sounds like there's some things.
That's certainly not it's not your number two.
Is there a way to quantify number 4 with how much it would use on the system with the service orders? Is that true with linked to number 1?
I think so. And here's why. Sue's giving me a look. Maybe not. No, because there is data on if people receive medications in jails, this is their outcome. Mm-hmm. This is length of stay. This is how many are restored to competence within just by getting medications alone. So I think it's there, maybe not a perfect fit, but it's a lot.
Well, if you can quantify that, maybe the capacity issue isn't as bad, right?
For sure.
Maybe more important to tie number 1 to number 4 than to tie it to number 2.
But we were talking about tying people.
I actually have a hard time saying we're only going to take number 1 if we do these other ones as well, because then I would say, well, I'm not going to support number 1 unless we do, volunteer engagement. So, I think if we put up, these are our top priorities because we think they go together well. They look at, earlier intervention. They look at trying to add some capacity. They look at, addressing this issue. There's, more transparency there. That we just make those our top ones because, what if we got, we'd want number 4 even if we couldn't get number 1 in terms of going through the session. So I hate for us to say we're not going to support this unless all of these are done, because that's really tough at the legislature, to be honest.
It's a difficult situation to say, okay, what we're gonna do is gonna take this, we had a problem in 2013. Tried to solve, wasn't successful, and so we're gonna shift the focus, and at least for some time, it's gonna get worse before it gets better. People waiting for chance. And that's a difficult thing.
Is it going to be worse for sure?
Well, if we're not gonna expand the capacity and we're gonna change the priority, it's gonna be at the expense of the people who are waiting for chance.
But what if?
People are intentional. And you see somebody who has more severe need in the correctional bed than in the community, you would still take the correction. It would be based on the individual need.
I haven't heard yet the idea that if we do this, it will become more efficient and this process will move more people from jails and more people from hospitals. I haven't heard of that.
Yes, that's what I thought we were hoping to do.
I think we're started out by saying that every stems from the problem with the mental health system, and we can't boil the whole ocean. So, it starts with the problem. There's been mental health capacity added writ large, but in terms of the ability to take type of people who go to Anoka, right? The criteria for people going in has become narrower and narrower as the population used to go there has gotten larger. And so that part of it hasn't expanded. And it doesn't necessarily have to be hospital beds. It could be spaces. It could be other things that take the place of that, but provide the same function as long as it's